Hi, my name is Ariel Bivas. I'm a nurse practitioner specializing in addiction medicine and palliative care. I practice at Penn Medicine and Ophelia Health. This video will review challenges, opportunities, and practical considerations for prescribing medications for opioid use disorder, or MOUD, namely buprenorphine via telehealth. Opioid use disorder, or OUD, remains a public health crisis in the United States. Annual overdose deaths peaked at more than 100,000 between 2021 and 2022. About 3.7 of U.S. adults, which is roughly 9.4 million people, have opioid use disorder. In recent years, the contamination of the illicit drug supply, combined with the isolation and treatment access challenges of the COVID-19 pandemic, has driven an increase in overdose deaths. Beyond overdose, untreated opioid use disorder carries serious consequences: infectious disease, mental health comorbidities, reduced quality of life, criminal justice involvement, and increased mortality from all causes. Despite highly effective, FDA-approved medications, fewer than a quarter of individuals in the U.S. with opioid use disorder receive pharmacologic treatment. Barriers include clinician shortages, especially in rural areas, stigma, and unclear regulations. Even though the Department of Veterans Affairs guidelines recommend buprenorphine, adoption by primary care providers has remained low, further limiting access. Patients also face their own challenges, like transportation and conflicts with work or childcare. There are 3 FDA-approved medications for opioid use disorder: methadone, which is restricted to federally certified opioid treatment programs and requires in-person dosing; extended-release naltrexone, which is available to any licensed clinician but sees limited use due to cost and because patients must be opioid-free for a period of time before starting. It also lacks the same robust evidence on reducing mortality as the other 2 medications. And then buprenorphine, which can be prescribed in office-based settings. Special waivers were eliminated in 2022, so any DEA-registered provider can prescribe it, including via telehealth. The COVID-19 pandemic catalyzed regulatory changes that opened opportunities for telehealth adoption. In March 2020, the DEA and SAMHSA allowed buprenorphine initiation via audiovisual or audio-only telehealth without prior in-person evaluation, leveraging the public health emergency as an exception to the Ryan-Haight Act of 2008. Those flexibilities showed telehealth's real potential to bridge the treatment gap. Telehealth adds flexibility for both provider and patient and can be used alongside in-person care depending on schedule, weather, patient acuity, and preference. Some patients start in person and transition to telehealth, others do the reverse. And while we can compare telehealth to in-person care, it's worth keeping in mind, without a telehealth option, many individuals wouldn't receive any addiction care at all. Before the pandemic, telehealth for addiction care was limited by clinician comfort, laws, reimbursement restrictions, and licensing requirements. Pandemic-era changes expanded adoption significantly. One ongoing concern is regulatory uncertainty. In 2022, the DEA announced that it intended to make pandemic general telehealth flexibilities permanent, but those flexibilities have been extended multiple times and are currently authorized through December 31st, 2026. A meaningful win came in December 2025. SAMHSA, on behalf of HHS and the DEA, published a final rule allowing DEA-registered clinicians to initiate buprenorphine via live, audio-video, or audio-only telehealth and prescribe up to a 6-month supply without an in-person visit. Requirements to do this include holding a DEA registration in the state where both provider and patient are located, checking and documenting the state prescription drug monitoring program before prescribing, and having the pharmacist verify patient identity before dispensing. After 6 months, continued prescribing requires an in-person visit or another authorized telehealth pathway. A proposed special telehealth registration is not yet finalized. State policies add complexity. Some states support telehealth expansion, others are restrictive. Interstate licensure can be a barrier, though the Interstate Medical Licensure Compact provides a pathway for multi-state practice. In terms of reimbursement, Medicare now permanently covers audio-only mental health and substance use treatment, but state Medicaid remains variable, especially for audio-only visits. Yes, it's a lot to keep track of. Access is supported, but the framework is complex. Staying up to date is part of providing care. Clinicians can also play a role by advocating for patient-centered policy. Another barrier is technology access. Telehealth can broaden who receives services, but not everyone has the same tools. At least 21 million Americans lack broadband access, and gaps in device ownership, digital literacy, spoken language, and age all affect who can participate. Providers need to adapt their practices and technology to reach more people. And while most providers ultimately appreciate the benefits of telehealth, learning new technology and changing clinic workflows takes time and energy. Pharmacy scrutiny can also create barriers. Some national chains require extra confirmation for controlled medications prescribed via telehealth, which can delay or prevent legitimate prescriptions from being filled. Privacy and HIPAA compliance add another layer of uncertainty, particularly regarding storage of video or electronic communication records. Finally, remote clinical assessments have real limitations. Some physical exam findings, such as pupil constriction or piloerection, may be harder to assess virtually. And while telehealth is safe and effective for many mental health conditions, research specifically on telehealth-delivered addiction care is still limited. Telehealth lowers geographic barriers and expands access to buprenorphine. It eliminates transportation, reduces travel costs, and accommodates work and childcare demands. This is especially meaningful in areas where in-person treatment options are few. The evidence is encouraging. Telehealth buprenorphine initiations show higher engagement than for in-person, a higher likelihood of refills, and lower odds of a medically treated overdose. Telehealth enables a low-barrier model of care defined by rapid medication access, minimal administrative friction, and flexible follow-up. In the fentanyl era, every day a patient waits is an overdose risk. Removing obstacles like wait time, travel, and the stress of crowded clinics lets patients engage in recovery and return to daily life without unnecessary burden. Patients value the privacy of telehealth and the flexibility of scheduling without sacrificing the time to transportation and waiting rooms. They report less social anxiety, and providers describe feeling less intrusive into the lives of stable patients. For patients going through buprenorphine induction, being in their own home is often much more comfortable. That increased comfort may actually enrich the quality of the social history and strengthen the therapeutic alliance, even when physical exam capabilities are limited. Patient selection requires thoughtful clinical assessment. Low barrier means meeting patients where they are, while also recognizing when telehealth is not the right setting. Individuals who are medically or psychiatrically unstable, or who can't engage safely in outpatient treatment, are better served in a more structured setting consistent with the ASAM levels of care criteria. As with in-person care, monitoring and follow-up remain essential. Track engagement through follow-up visits and reassess safety and risk over time. When clinically indicated, synchronous point-of-care oral fluid or urine toxicology testing can be incorporated into telehealth care. Reviewing results together during a video visit can engage the patient in shared problem-solving rather than being punitive. ASAM guidance emphasizes that requirements for ancillary services, including toxicology testing, should not prevent participation in addiction care and may be delivered via telehealth when appropriate. Continue naloxone co-prescribing, which is recommended for all patients receiving treatment for OUD. While physical exam is limited in an audio-video visit, overall assessment may be richer when a patient is in their own environment. For buprenorphine induction, the COWS, or Clinical Opioid Withdrawal Scale, can be adapted to a SOWS, or Subjective Opioid Withdrawal Scale, with patients monitoring their own status or relaying symptoms to the provider. Frequent electronic check-ins during induction can reinforce patient agency in their care and recovery, which may deepen trust. And while induction often gets the most attention, a large percentage of patients choosing telehealth are already stable in treatment. They're simply looking for maintenance care that doesn't interfere with their daily lives. Telehealth is ideal for this. In order to effectively provide telehealth for OUD, providers do need to stay current on regulations and ensure documentation aligns with regulatory and payer requirements. Federal and state rules governing telehealth continue to change, which can affect prescribing authority, reimbursement, and cross-state practice. Another tip is to address pharmacy challenges proactively. Build relationships with pharmacies and be prepared and open to provide additional information when needed. Telehealth has expanded the reach of buprenorphine for OUD for populations who may not have previously been able to participate in treatment. Evidence shows higher engagement, improved retention, and reduced overdose risk. Low-barrier approaches that prioritize quick access and minimize administrative hurdles make a real difference for patients. Since December 2022, any clinician with an active DEA license can prescribe buprenorphine without a special waiver, allowing more providers to offer this life-saving treatment. Stay informed of the evolving regulatory landscape and consider advocating for policies that maintain telehealth flexibility and expand evidence-based treatment options.